everyone. Welcome to the December LACNETS meeting and our holiday lunch. I hope you're enjoying the nice hot buffet. So a few announcements before I introduce today's two wonderful presenters. We have two save the dates for you. Our next LACNETS meeting will be on January 10th, a Tuesday, at Cedars-Sinai in the lower conference center, the usual room that we have at Cedars-Sinai. And the topic's pending, but we will be announcing that shortly. And then the second save the date is February 4th is the annual NET conference in San Francisco, put on by Stanford, UCSF, NetRF, and NorCal Carsonet. So with that being said, I will introduce our speaker today, our first speaker, Dr. Run Yu. And he is the Associate Professor of Medicine at the David Geffen School of Medicine here at UCLA. Dr. Yu earned his MD degree from Peking Union Medical College in Beijing and his PhD in pharmacology from the University of Rochester in New York. Dr. Yu also completed an endocrine research fellowship, an internal medicine internship and residency, and a clinical endocrinology fellowship at Cedars-Sinai and UCLA. Dr. Yu's clinical and research interests are in neuroendocrine tumors, especially in pancreatic neuroendocrine tumors, and pheochromatoma. You can say it way better than I can. So without further ado, here is Dr. Run Yu.
Okay, so Linda just showed me how to advance the slide. Okay, happy holidays, everyone. Yeah, I see a lot of familiar faces and the best wishes for Giovanna's treatment. Okay, so today, I pick up this topic because I wrote a piece at the Carsonet Foundation website on genetic causes of neuroendocrine tumors a few months ago, and according to the website organizer, they got one of the highest hits on this article. So I think this might be something interesting to other patients as well. So that's how I determined to discuss about this, the familial syndromes, the genetic causes of neuroendocrine tumors. It will have three parts. The first one is that why familial NET syndromes are important, to all of us. Second, we're going to discuss three common familial NET syndromes. And the last part is kind of my favorite part, that how a new familial NET syndromes was discovered actually based on our work at the Cedars-Sinai. I'm sorry that we have to do a little bit of background scientific teaching, but there are only two slides, very simple. So this is the first slide called Genetics 101. So all of us have two copies of the same gene. One copy is from father, one copy is from mother. And so if one gene is wrong, sometimes we got a disease, then this is called a dominant disease. If two genes have to be wrong, so that we'll have a disease, and this is called a recessive. And just one more slide, and that will be it. There will be no more genetics background. And the 102 is really that related to the pathogenesis or the cause of tumors. There are two kinds of genes that are related. One is called a tumor suppressor gene. So this kind of genes suppress tumor formation. During our life, we got many kinds of insults such as UV exposure, chemical exposure. So there will be some abnormality in the body, but the tumor suppressor gene will keep them at bay. The second part is second kind of gene they call the oncogene. So this gene are normal genes, but if for whatever reason the gene is activated by mutation, they can cause a tumor. Of course, nobody can remember this. Even I myself cannot remember, although I wrote this slide. But basically, there are so many kinds of familial neuroendocrine tumor syndromes. And the reason I put it there just to appreciate that there's a wide variety of syndromes. And most people do not have the syndrome, but the insight we get from those syndromes actually apply to every patient. This small bowel carcinoma usually does not have a known genetic cause. So very, very rarely, you have a family with multiple members with a small bowel carcinoid. Well, the pancreatic neuroendocrine tumor is the most common type that will have a genetic component. Usually 5 to 10% of people with pancreatic neuroendocrine tumor will have some sort of a familial cause. And there are actually 5 syndromes, and we don't have to go into the details, but the common one is the MEN1, which I will discuss more in detail. Lung carcinoid also rarely runs in the family, but in MEN1, the syndrome which has pancreatic neuroendocrine tumor, sometimes patient will have a lung carcinoid as a component, but it's not very common. And other neuroendocrine tumors, it's very variable for this tumor to have a genetic cause or not. The why genetic syndromes are important. They're actually not very rare if you consider them as a group. So every single one of them might be rare, but if you put them together, it's actually pretty commonly seen in clinical practice. The other thing is that this kind of syndromes do not have any geographic or culture bias or preference. So this is very fair. Everybody can have this. So no matter rich or poor, whatever race, because you can simply have this syndromes. And their natural history is unique and predictable. So for example, if you know a patient has a syndrome, you can more or less tailor the surveillance and the treatment to that patient's unique syndrome. And of course, genetic counseling is important, and this syndrome requires a comprehensive management because the tumor may not be limited to one organ. The patient may have a new tumor coming in the same organ, so we need to do a expectant and comprehensive management to this patient. And the knowledge learned from genetic syndromes actually can be applied to non-familial NETs as well. I will give you one example. For example, nowadays many small incidental pancreatic neuroendocrine tumors are discovered just by routine imaging. Then someone has a hypervascular tumor, a smaller one in their pancreas, and we really do not know what to do with them. We know they grow pretty slowly, but do we need to resect them, or can we keep them there? Actually, we use a lot of the literature from people with MEN1, the syndrome that has pancreatic neuroendocrine tumor, as a guidance. For example, we know now if the tumor is less than 1 centimeter, probably it's safe to keep it there if it's not functional. So the common features of familial syndromes are that they're mostly caused by a mutation of the tumor suppressor gene. So that is the gene normally suppresses tumor growth, but then the mutation makes the gene not active, rarely due to some activating mutation of oncogenes. So they may involve multiple organs or maybe just one organ. And we're not going to worry about the organ selectivity. And most of these are dominant disease. So if a parent has it, the chances that the parent's children, any children of the parent will have a 50% chance of inheriting this disease. And they're very rarely recessive, but we're going to talk about the recessive one in a little bit later. And there's pathologically, so on the tissue specimen, there almost always there are so-called pre-neoplastic endocrine cell hyperplasia. For example, in people with MEN1, there are always hyperplastic on the larger islets. So that's suggesting that the tumor formation process kind of persists throughout life. So they are always there, but they may not form a dominant tumor eventually. But the pre-tumor or pre-cancer abnormality is always there. And a question always asked by patients that, so is this bad to have a NET syndrome? Is this, of course, not a good thing. We do not want to have a disease syndrome, but is this bad? So actually not necessarily. So that the tumors of any NET syndrome, they are still, NETs. So they are not a different tumor. And the tumor behavior actually is a little bit better if you compare like tumor by tumor. For example, if there's a familial syndrome, and there's, say, 3 tumors. But then if one tumor is, say, 3 centimeter, that 3 centimeter tumor does not actually behave worse than a sporadic tumor. Most time it behaves a little bit better, mostly because we found the tumor early on, so that we monitor tumor more carefully. And there's a few other issues. We mentioned that the patient children need to be screened, and if one of the children actually has the gene, then they have to be prospectively followed to make sure we catch any tumor early on. And the other thing is that because this is a syndrome, so other tumors other than the first tumor the patient has, may become obvious in the near future. So we need to pay attention. And the other thing is that it's very hard to cure this familial syndrome unless you do gene therapy. So the tumor will continue to happen, but again, they may not be very bad tumor, but the tumor will continue to develop even when the patient is very old. And the other thing is that patients often ask me, so you mentioned this, but do I have an AET syndrome? For example, you may have a small bowel carcinoma, then chances are it's not familial. But you have a pancreatic neuroendocrine tumor, there's a chance it may be familial. But what are the clues of an AET syndrome? The first one is younger age. For example, you were diagnosed at age 80 with a small pancreatic AET, it's probably not a familial syndrome. But if you are 18, then you have an insuloma, then the chances are that there might be a genetic component of it. And the other thing is that one patient may have multiple tumors. For example, you not only have a pancreatic neuroendocrine tumor, there might be a parathyroid tumor or pituitary tumor, or in the same organ, there are two tumors. So for example, if on the first presentation, the doctor found two incidental pancreatic tumors, then we worry about the familial syndrome some more. Of course, the family history of a similar neuroendocrine tumor or a different neuroendocrine tumor also is a red flag. And the other thing is that on the tissue specimen, even the normal margin of the tumor, if you see pancreatic or other endocrine cell hyperplasia, then that is a concern for a genetic syndrome. So if you are diagnosed with a genetic syndrome, then most likely this is a known syndrome. So we need to obtain a complete family history. We do blood tests and imaging periodically. We do genetic counseling, and we also may do a larger scale genetic testing, not limiting on a gene that we suspect. And if you're so for example, you have some red flags of a familial syndrome, but really we test a lot of genes, but then none of them showed up to be positive. Then the patient may have an unknown genetic syndrome, which is actually possible. So we're going to touch upon this a little bit later. So the first part is that why genetic syndromes are important, to all of us. The second part are just the three most common genetic syndromes. The first one called MEN1, multiple endocrine neoplasia syndrome type 1. You can see this is pretty rare, but not that rare. So one in 30,000 births. Since I joined UCLA, after I left Cedars, I have seen two patients with MEN1 here. Actually, one of them I identified. The other one is one I inherited from another doctor. So they are clinically defined as two of the three tumors. Or you have only one tumor, but you have a family history. The three tumors are parathyroid adenoma, a pancreatic neuroendocrine tumor, and a pituitary adenoma. Other tumors, as I mentioned earlier, such as tumors in the thymus and the lung, are also possible. Recent studies show that maybe meningioma, breast cancer, and prostate cancer are also a little bit more common. But most of these tumors are benign, but they can become malignant and metastasize to the liver. So there are some actually interesting facts about MEN1 that even say a regular endocrinologist would not talk about. So one is that actually 10% of people do not have a family history. It's not because they are illegitimate son of someone. They just they can have a de novo mutation. So it just the mutation just happened, and the other 10% actually do not have a known mutation. So they have everything of MEN1, but you do the gene testing, we could not find a mutation. The other thing is that parathyroid adenoma and pituitary tumor are pretty common as we get older. For example, if I do a pituitary MRI, I might have a pituitary adenoma. So I'm very serious because this is pretty common after you turn 50, you got a adrenal adenoma, pituitary adenoma discovered. So you may have both of this at an older age, but does not mean you have a familial syndrome. But the pancreatic neuroendocrine tumor are more specific. So that is, if you have a pancreatic neuroendocrine tumor and you have multiple tumors, you have endocrine cell hyperplasia, then the chances are higher the patient may have MEN1. And so it requires yearly biochemical follow-up and imaging every 2 to 3 years. And the starting age should be individualized according to the patient's history. This is a real patient I saw in UCLA. So she's only 30, but she presented with a vision loss, and turned out she has a large pituitary tumor. But she also has a known history of parathyroid adenoma, actually resected a few years ago. Now the parathyroid adenoma comes back. So she has 2 of the tumors at a young age. So this is very suggestive of MEN1. So I did genetic testing. Actually, she does have a mutation. And the abdominal imaging actually shows she got multiple small pancreatic neuroendocrine tumors. But so you can see that her other doctors did not connect the dots, thinking, okay, you have 2 tumors, so, you have 2 tumors. But we were able to connect the dots and show that she has a syndrome. This is actually very important for her prospective care, also for screening her children. MEN2 is also not that rare, but pretty rare, about 1 in 4,000. This is due to a mutation of an oncogene. The most common component is medullary thyroid cancer, and second followed by pheochromocytoma. I know these 2 tumors are usually not discussed a lot of our LACNET meetings, so I'm going to just won't spend too much time on this. So we can talk about von Hippel-Lindau disease. So this is another disease that has a 1 in 4,000 incidence. That is in every 40,000 babies born, one of them may have von Hippel-Lindau disease. This is more pertinent to the patient with pancreatic neuroendocrine tumor because pancreatic NET is a component of von Hippel-Lindau disease. Again, this is autosomal dominant like the MEN1, and this is due to a mutation of the gene, of the tumor suppressor gene. There are 3 subtypes, but again, I won't. You can see that the pancreatic neuroendocrine tumors were not even listed as a criteria for classifying the subtype because the pancreatic neuroendocrine tumors are usually not the dominant disease of people with von Hippel-Lindau disease. So depending on what you read, anywhere between 15 to 50% of people with von Hippel-Lindau disease will have some abnormal pancreatic neuroendocrine abnormality. Usually it's a small tumor or all the tumors are non-functional. So rarely there's a functioning tumor from von Hippel-Lindau disease. While in MEN1, carcinoma is the most common functional neuroendocrine tumor from the pancreas. So again, I listed this to just give you the impression that we have many, but so look at the last one called Mavash disease. So this is actually a disease that we at the Cedars actually discovered ourselves. So I want to share with you, this is kind of interesting in that, this is kind of like the best thing I have ever done in my life. But the other thing is that we can see that even here locally, just based on routine clinical care of our patient, we can discover something novel and generalizable to other patients. So if I talk too much, just stop me, yell at me, stop, and then because I can drag on for hours. Because my daughter, I always say, whatever you talk about, you eventually divert the topic into the disease you discovered. I say, yeah, it's kind of true, but we'll see. Okay, so this is a patient I saw actually 2 years after I joined the Cedars faculty. She's still alive. She's followed the Cedars. Her first name is Mavash. Anybody know what Mavash means? It's a common person name. The Mavash means full moon. So apparently in the Persian culture, I know in Chinese, many girls are named after the moon, but that look like the same thing in the Persian culture. It look like so the face is kind of round and full, meaning you're healthy or something. But in endocrine world, we do not like a full moon face because that's suggesting of Cushing's syndrome. But in that culture, like a full moon is a sign of beauty. Okay, so she's a 16-year-old. She does have again, Dr. Heaney actually has been an intrinsic part of this discovery. So this patient has a pancreatic neuroendocrine tumor with very, very high glucagon level. Glucagon is one of the pancreatic islet hormone. The most famous one, insulin, glucagon is the second. You may have heard the term glucagonoma. So this is really high, but she really does not have any symptoms of a glucagonoma syndrome. Her pancreatic polypeptide levels are a little bit elevated, but all other hormones are normal. Occasionally, she even has hypoglycemia. So she underwent a partial pancreatectomy with tumor resection. In her pancreatic margin, there are a lot of hyperplastic islets, abnormal islets. Remember I mentioned early on that multiple, smaller or large islets with hyperplasia, even in the margin, not inside the tumor, is suggestive of some kind of genetic syndrome. And the other thing is that she has a very high glucagon level, but really without any symptoms of glucagon. I know some of you may have a glucagonoma syndrome, so that is rash, diabetes, mouth ulcers. It's a horrible disease to have, but she does not have any of those. So at that time, we figure maybe she has some, different genetic makeup. So we sequence her glucagon gene and her glucagon receptor gene. The glucagon receptor is the molecule that actually make a glucagon work. So the glucagon receptor is expressed in the liver. The glucagon goes to the liver and does all the things we know of, for example, raising glucose levels. So we're very lucky. We actually show that she has a homozygous mutation in the glucagon receptor. So we did more a biochemical study to demonstrate that this mutant receptor actually is not working. You can see this is believe me, I even framed this and put it in my living room to brag to other people. Yeah? So, and then, so what's more interesting is that, so I actually gave like a more academic talk of this in China. I'm just saying this is a very rare thing. You guys will probably never see this on your own. But then a pathologist from Memorial Sloan Kettering, and you probably all know her, Laura Tan. You probably know her because she's one of the authors who shows that there are somatic mutations in pancreatic neuroendocrine tumor in the famous Science paper. She's a very famous pathologist. She was actually in the audience. She said, Doctor Yu, I think I have a patient with myopathy. I say, come out. It's impossible. Then we studied more. Looked like so. This is the family. So this patient is a 40-year-old male, with a high glucagon level, and he did a pancreatectomy and also showed diffuse endocrine cell hyperplasia. And after surgery, her glucagon level is still high. And it's very interesting that his brother had exactly the same condition. Also, his double first cousin also has a condition. It's very interesting that his mother and father and his cousin's mother and father were brother and sisters respectively. So basically, two brothers married two sisters, which is very interesting by itself. But so only in this case you can have so basically your double first cousin can have the same disease as brothers have. All other cousins are very, very unlikely. So in this case it shows that. So actually, sequence this patient, and we also saw two mutations. Remember I mentioned that we have two copies of the same gene. Both copies have to be wrong to cause the disease. And in this patient's case, that the mutation actually on different copies of the gene. So both copies are bad. So they got this syndrome. And we can so basically we sequence the 10 family members of this extended family. And if you have two of the mutations, the three brothers and the double first cousin actually got this disease. Well, for all other people, they were just carried, they just got one mutation, and actually they were fine. So actually now, there are 11 cases reported. So Dr. Klopel from Germany reported 3 cases, and recently, just last month, another case was published. So the reason I know that case was published because I reviewed that paper, so I know the paper was accepted and published. So we can now have 11 cases of the same disease. So we actually made it to a lot of rare disease websites. So this is probably legitimate new disease. So we can see that 8 of them have the mutation, and the patient really all over the world. So we actually had an animal model for this. So the mice without glucagon receptor basically have the same disease. So they have endocrine cell hyperplasia, very high glucagon levels, and also pancreatic neuroendocrine tumor. But the nice thing with the mouse model is that from the mouse model we show that both males and females can have this, and the carriers are really fine. So and we also confirmed the genetic makeup of the disease. So okay, we mentioned that. But the last point is that even in very old mice, you can still see the endocrine cell hyperplasia and a new tumor formation. So that shows that even in patients, we need to monitor them continuously. Okay, so I think, yeah, so that will be it. And so in conclusion, we discussed the importance of familial syndromes, and the knowledge we gained from familial syndrome can be applied to people without familial syndrome. And we know that the familial syndrome share common characteristics and what are the red flags of having familial syndrome. And we discussed the 3 syndromes, the most common one, and we also discussed my interesting journey of discovering a novel familial syndrome just based on clinical practice right here in Los Angeles. So I think the last page is especially interesting because it shows that by working together, patient and doctors, that we can discover some new findings to guide the patient care. For example, for that patient, we have followed for 10 years after the tumor resection, and we're continuing to do MRI regularly because there's a chance she will pop up another new tumor in her pancreas. Thank you very much, and happy holidays, and feel free to ask me questions.
A little about Dr. Girgis. He's the assistant professor of surgery here at UCLA. He received his medical degree from Loyola University in Chicago. He received advanced training in robotic surgery and surgical oncology in his fellowship at the University of Pittsburgh. His interests include robotic and minimally invasive approaches to surgical oncology, and more specifically on pancreatic diseases in his clinical practice as well as his research endeavors. He is one member of the group of pancreas surgeons here at UCLA, and his research endeavors focus on developing novel peptides targeting pancreas cancer for these words are getting me, radioligand therapy. How do you say that? Yeah. Right? Okay. And is part of a multidisciplinary group that collaborates on a variety of projects centered on developing new therapies for cancer patients. So without further ado, Dr. Mark Girgis.
If it's okay with you guys, I'm going to try to not use the podium and project my voice.
He has a big voice.
Is that okay? Can you guys hear me in the back? You can. Okay, it's not that big a room, right? It's okay. I'm not as impressive as Dr. Yu. I haven't developed my own diseases or anything like that. Maybe in the next 20 years or something. But I'd like to talk a little bit about some of the surgical therapies that are available for specifically more for pancreatic neuroendocrine tumors, but it tends to apply a little bit for gastroenteropancreatic neuroendocrine tumors also. Great. So 3 objectives today. The first, talk about the current role of surgery. The second, I'm going to provide some evidence to the group here about where we can maybe expand surgery into the treatment of neuroendocrine tumors. And then the third is to talk about some of the new advanced techniques, as you heard from the biography, I have a special interest in minimally invasive approaches, and I think those things can be applied to patients with neuroendocrine tumor. So, as you all know, this is just a very brief overview. Neuroendocrine tumors, they occur in different locations, the pancreas, the intestinal tract, and in the lung or the chest. Then after you understand the location, you try to understand the functionality, whether it's hormone active or hormone inactive. Thereafter, we like to understand also the grade, or if it's well differentiated or poorly differentiated, because that helps determine the biologic nature of the tumor. And then lastly, that's how we determine the treatment. So this is the general approach we have to all of our neuroendocrine tumor patients. This is the pancreas. I present it here just so you know that when I refer to things later in the presentation, you know what I'm talking about. It's divided, it's an organ that sits like literally across the middle of our abdomen. It's divided into 3 sections, a head, a body, and a tail. Very simple, 3 sections, head, body, and tail. Let me also just say that in the pancreas, there are these islet cells, different types, and those can be where the functioning neuroendocrine tumors develop. This is how we grade or how we get grade essentially, or how well or poorly differentiated we define the tumors. I'm going to focus here on this like half of this slide here. More recently, we had initially 3 groups of patients, grade 1 and 2, grade 1, 2, and 3. We've kind of gone away from that, and in the last 10 years, it's been sort of the consensus that there are only 2 kind of big groups, the well-differentiated group and the poorly differentiated. You guys probably know this already, and it's defined essentially by these pathologic things that we see when we look at tumors under the microscope, whether there are a lot of dividing cells, or whether there are less dividing cells. If there are less dividing cells, they're generally well differentiated. If there are more dividing cells, then they're more poorly differentiated. And this is specifically important because it affects how we decide to guide treatment. So this is, again, another general treatment algorithm for patients with neuroendocrine tumor, not necessarily just of the pancreas, but to other areas. So the first thing, you're diagnosed with the disease. We generally separate into 2 groups. Those who have local regional disease, which means that the disease is confined to the organ that it starts in, or the lymph nodes around it. That's local regional disease. Metastatic disease is disease that has spread from that local area, from the lymph nodes and the local area, to another area of the body, wherever it is. That's considered metastatic disease. So those are the 2 groups. And you can see that, very easy to figure out what to do if the patient is in that local regional group. It's very easy. They generally just go to surgery to begin with, and then that can further guide therapy. The patients that have disease that is spread out more, this is where it becomes a little bit more tough to define the therapies for patients. It includes surgery, chemotherapy, just observation, and maybe some somatostatin analog, that's SSA, somatostatin analog, and then some other things also that are not the focus here, but a lot of different things for patients with disease that is spread outside the local area. I'm sure you guys are all aware of this group, the NANETS, the North American Neuroendocrine Tumor Society. I just wanted to show you this because this is actually an area of controversy. I'm just literally going to read it to you. Progression of liver metastasis is the predominant cause of mortality in NET patients. Median survivals range from 2 years to, many years, 10 years. For this reason, hepatic resection, radiofrequency ablation, hepatic arterial embolization have been used to treat or control tumor burden in those patients in whom all hepatic metastases seem to be resectable, and in whom no extrahepatic disease is observed or clinically insignificant diseases, resection should be considered. It just says considered. It doesn't say recommended. It doesn't say anything like that. It's just a consideration. The lack of randomized data and selection bias may confound quantitative interpretation of reported results. I'm going to show you some of those reported results. Nevertheless, resection should be considered in carefully selected patients, particularly functional tumors, because it can help with symptom control. In asymptomatic patients, in the setting of resectable disease, should also be considered as candidates for surgical debulking. So this is what they say. It's just a point that we need to recognize that it's not necessarily accepted that people need surgery for metastatic disease or can get surgery for metastatic disease. It's more, we have to be more thoughtful than that. Now this is the NCCN. NCCN is another cancer network that develops guidelines, and they're published every year. And these are, I highlight here the surgical principles for management of neuroendocrine tumors. And I'm going to, again, bring out a certain area. As Dr. Yu said, whenever the tumors are small in the pancreas, specifically in the pancreas, you can just observe them or something. But let's bring out something here. Resection of recurrent local regional disease, isolated distant metastases, or previously unresected tumor that has regressed, you could consider them for surgical resection if it's possible. Whoops, sorry. Patients with symptomatic recurrence, if you can remove more than 90%, experienced judgment is required. Planned cytoreduction, which means you don't get all of it, and you leave some behind, it is, again, controversial in patients that don't have any problems or any symptoms from their disease. These areas haven't been elucidated yet. So based on that, I'm going to give you just some evidence out there that's available to review. I'm a surgeon. I like surgery. I like to do surgery. I recognize that, and that's why I'm talking about this. But I would even caution you to take what I'm saying with a grain of salt. These decisions really need to be made not by one person, but by a group of people. There was another gentleman who just left, Dr. Heck. He's an oncologist. Dr. Yu, an endocrinologist. Generally, groups of physicians to determine these more complex cases need to be incorporated. So this is just for pancreatic neuroendocrine tumors. This is just a big study that we have these databases, these national databases that we can extract data from. They're very not granular, and just in general, this study suggests that if, again, localized disease or local regional disease, patients generally do very well. 10 years plus with overall survival. Patients do very well. Whereas if it's metastatic, it's less, but better than if you were not to remove it. Again, these are different. These are all patients, whether the tumor is well differentiated or poor differentiated. And I will tell you also that patients that get surgery, they tend to do better because they probably have just less disease in general. Again, going into where the multidisciplinary group has to be thoughtful about making decisions. Where I trained in Pittsburgh, this was kind of shoved down our throats there because this article is from Pittsburgh. That's why I know it so well. But they just demonstrated the same thing. You see these curves, how patients that, when they don't have distant metastases, if you remove them, much better. This curve that's being higher means higher survival. And the same, when you get no resection, you're lower. If you get some resection, you're in the middle. But if you get both the primary tumor and the tumor elsewhere, patients tend to do better. Again, take it with a grain of salt, please, because these are very large database studies that are not very granular. Now, this paper is out of Italy. This group in Italy, they do a ton of pancreas surgery. They published their series on just removing the primary tumor and not the metastatic tumor of patients with neuroendocrine tumors. And they actually, I didn't include this on the side, but they actually didn't show any survival benefit, but they did say that symptoms, whether it's pain or vomiting or weight loss, tend to be better when you remove the primary tumor. Again, this has to be a case-by-case basis for somebody who's safe to go to the operating room, things like that. But it can not just help with overall survival. If it doesn't help with survival, it can help with just control of symptoms. So again, this is a group from Germany now. This guy here, Buchler, is one of the biggest surgeons in Germany who does this stuff. And this is just a recapitulation of what I've shown the last 3 slides. People that tend to get surgery tend to do better. The last point I want to make about surgery here, which is I think most of us in this room recognize that when patients have well-differentiated tumors, which tend to grow slowly, as Dr. Yu said, and if the disease can be removed, patients will do better. There's some controversy, though, I will say, about the poorly differentiated, the high-grade tumors, which are historically have been tended to treat sometimes with surgery, but more often with chemotherapy. And this group here, they suggested that patients who, this yellow line are patients that get surgery and chemotherapy, and this red line is patients that don't get either. And these 2 lines are patients that get chemotherapy only, that the patients that get both surgery and chemotherapy tend to do better. Again, indicating that there may be some role for surgery in this group. So this is kind of what I wanted to spend a little bit of time on, and I'll explain a little bit about these operations. So this is, Dr. Yu was talking about how tumors that are neuroendocrine, they tend to have a lot of arterial enhancement on CAT scan. That's it right there. They're very easy for us to identify with a good CAT scan. Very easy because a lot of contrast will be taken up in the tumor. This type of tumor in the pancreas, because of its location, would require a surgery where we remove the head of the pancreas, the intestine that surrounds the pancreas, the gallbladder, and part of the bile duct, and then we reconnect everything. We reconnect the bile duct to the intestine back to the pancreas, and then the stomach here back to the intestine. It's a very complex surgery. It takes a long time. It's called the Whipple procedure. It takes about 6 hours. It's one of the most complex surgeries we do. And this is the classic surgery for pancreatic head tumors, whether it's a neuroendocrine tumor or a regular adenocarcinoma. The other one, the converse, is whenever the tumor is to the left side of the body, in the body or tail, we do this thing called the distal pancreatectomy, which is we just cut this last portion of the pancreas off, include the spleen because we want to get those lymph nodes, and there does not need to be any reconstruction in this case. This is a much more straightforward surgery in general. These are the 2 classic pancreas surgeries that are performed. The special thing about neuroendocrine tumors is, as again Dr. Yu was mentioning, whenever they're small, there's been data that has been recently published that maybe we don't need to be so aggressive in our surgical resections. The lymph nodes generally don't need to be removed, and we can do these procedures that don't remove a whole half of the pancreas. We don't like removing so much of the pancreas because it has biologic functions for us: insulin secretion, glucagon secretion, enzymes that help us digest food. If we can do limited surgery, then patients tend to have better outcomes. In this case, the tumor is literally right in the middle. So you can imagine if we remove the right half of the pancreas, it's like this big procedure. If we remove the left half of the pancreas, we're removing greater than 50% of the pancreas. We try to avoid those things. We can actually just, for neuroendocrine tumors, we can actually just remove the middle portion of the pancreas and reconnect it to the intestine and stop there. It's a lesser procedure than either 2. Mentioned before. And then finally, this idea of what's called enucleation, which is just cutting out the tumor and removing no pancreas with it. And this is recommended for small tumors that are as you can see right here on the CT scan, that are not close to the main pancreatic duct. The pancreas has this main duct that runs right in the middle of it. If you cut that duct, then you could have a lot of leak of fluid. But if it's not close to that duct, you can cut into the pancreas a little bit and just remove this thing. Obviously, you can see by this diagram here, it's the least of all operations. It's much less involved and much better for patients. That's what neuroendocrine tumors of the pancreas help us do. Understanding their disease biology helps us to do smaller things so that patients can recover quicker in general. Now we get to what my specific interest is, and I won't spend too much time, but minimally invasive pancreas surgery. I have been trained, like was mentioned, at Pittsburgh. They have the largest experience of minimally invasive pancreas surgery in the country, and maybe even the world. That they do these small incisions right here and put these trocars, we call them, into the abdomen and blow the abdomen up to have visualization, and do it like we would removing a gallbladder. Gallbladders were removed with these 5-millimeter incisions, started 20 years ago, and now some of this technology is being applied to pancreas surgery and is applied to pancreas surgery. Specifically, I say minimally invasive here. It can be done laparoscopically, which is how we do the gallbladder surgery. The group in Pittsburgh and where I've been trained, we like to use this thing called the robot. It's the Da Vinci robot. It's been out there in the news a lot. People may have heard of it. We tend to feel like we can do a little bit more advanced things with the robot versus the laparoscopy. But this is how it looks on your abdomen. And that's like just a diagram, but this is how it looks. This is how it looks. These are the pictures of how it looks. I hope nobody gets disturbed by these images. I don't mean it to disturb anybody, but I just want to show you the contrast of what's possible. And I'm not saying minimally invasive surgery is for everybody or that everybody should have that, but you can see big, open, this is a vein that's very big, that's in the middle of things. Somebody's holding back the intestine here, and you end up with this incision here that's healing just fine, no problems, but it's a big deal to go through an operation to have that type of incision on your body. Whereas, and you can see that this is generally the view we get from our eyes. It's about that far away. This is a picture taken from a surgery that I did here, and one of my patients, that you can see that it's magnified. We're using these instruments that articulate as hands articulate. The laparoscopic instruments tend to not articulate. They're like arms like this that operate. These hands of the robot, they articulate like this and like this. It's amazing. Yeah, it's amazing. It's amazing. I mean, somebody super smart developed these things. I'm just using it. But it really is a very nice thing, and Pittsburgh has published extensively on using this platform, the robotic platform for surgery, and they have great results from this. And this is kind of what it looks like after, this was a month after the surgery. This is a month after the surgery also, about a month. So I'm excited about it. Yeah, I think it's really cool, and I think it helps patients a lot. The data would suggest that patients recover a lot faster from this than the bigger incision, as you can imagine, and as been shown for when we went from doing our gallbladder surgeries from this big incision we would make along the right side of the abdomen to the laparoscopic area, the length of the hospitalization went down significantly. Patients recovered so much faster. It's the same idea for starting to use these minimally invasive techniques to do surgery. Now again, you can do it laparoscopically. I can't, but There are people that can do it laparoscopically, and still, even still, this open incision here is still very much the standard of care for this. This is more novel, not experimental, but novel. And lastly, I'd just like to acknowledge the group of surgeons I work with, this group here, the pancreas surgeons. And in this group, we're only part of a team that includes the oncologist like Dr. Heck and the endocrinologist like Dr. Yu in trying to take care of patients with neuroendocrine tumors, being thoughtful about what's to offer them, whether it's surgery or somatostatin or just observing patients or PRRT as mentioned. It's part of a bigger machine, and I'm happy to be a part of it, I have to say. And thank you guys for allowing me to talk a little bit up here, present some exciting things that we have going for us, and I wish you guys happy holidays.
My question has to do with repeat surgeries. For a patient, to be general, who's had maybe a large resection, maybe primary, at what point do you see the possibility for repeat surgery, especially something minimally invasive, or is it one time around and that's it?
No, again, as actually, it's actually in one of the slides. Surgery for recurrent disease is totally an acceptable form. It depends on the person's tumor, whether it's a highly aggressive tumor or a less aggressive tumor, and then planning it based on those features is another aspect. Whether you can wait for a little while, because who wants a surgery every year? I mean, that's kind of annoying. But so it's a little bit more thoughtful. So the answer is yes, but it's more thoughtful than just everyone who has a recurrent disease can get surgery. It's about timing, about palliation with maybe a somatostatin analog or whatever it is until another point in time. But yeah, definitely. And it is possible minimally invasive. I will tell you that there are the group in Pittsburgh. They have two contraindications for using the robot. One is if the patient has had surgery prior, and when you start the surgery, it looks like there's a lot of dense scar tissue. That's the first, because it tends to take a lot of time to do it that way, just time. And then the second is for Jehovah's Witness, unfortunately, just because of the risk of bleeding.
I don't add one sentence that for people with neuroendocrine tumor familial syndromes, reoperation is a routine. They always need multiple surgery. So on principle, I totally agree with Dr. Girgis.
I have a question for Dr. Yu about familial syndromes. And for patients who may not be near a major medical center like this, we see often that their hereditary syndromes sort of get missed. If you were talking to a patient who might suspect that, but their doctor hasn't, can you give any advice about how they might approach that conversation?
Sure. Yeah. So first of all, that I and many of us routinely do sort of like a friendly consultation to patients who are outside our region. For example, I routinely communicate with patients from all over the country about a unique syndrome that they can send me information. I cannot give them a formal opinion because they're not my patient per se, but I give a friendly suggestion to their physicians. But if you want to talk to your physician, you can just tell them that I recommend them to say that, oh, I just attended a seminar, rather than saying, oh, you read on the internet, because a lot of physicians are very defensive about the internet because they feel they are a better resource. But I'm not. But you just say that I attended a seminar where so-called some experts said something, but I feel I have a few components that I won't talk with you about it. If they are open-minded, and most of them are, and then they can do further tests. But you say, yeah, I'm willing to help, but I do not know what exactly genes to test, and you can communicate with the expert and just say, all right, the best way that the physician communicate directly. Because oftentimes the information is lost in translation. We'd rather to communicate directly and say, hey, please do this, and they're going to do this for you. And again, although I'm not paid, but we are working at an academic center, we do not mind for spending some time for this.
Thank you. It's great. Any other questions?
It's a surgical question. The difference between VATS versus Da Vinci, what makes that decision at surgical?
Yeah, VATS, you said? VATS, V-A-T-S. So VATS stands for Video Assisted Thoracoscopic Surgery. So in the chest, that's for thoracoscopic means chest, or laparoscopic means abdomen. Minimally invasive thoracoscopic means chest with a camera. And so in general, VATS is any type of video-assisted surgery, which includes Da Vinci. So it's a general term. It's more general term. But the chest surgeons, the thoracic surgeons, they definitely use the same platform, the same Da Vinci platform. They can do the same things, the same small incisions and everything. Historically, VATS has been, they use the camera, but they still make these like little bigger incisions to actually work in between historically. But with the Da Vinci, I think they're able to now make smaller incisions and just work with the robot.
I've seen this, this modeling. I think it's a European company that put together this three-dimensional preoperative modeling program where they're looking at what could be construed as almost solid, imagery of pre-planning for surgery. Is this something you've seen or you're aware of?
Yeah, so 3D modeling of anatomy is very popular. It's used more than anything else in vascular diseases, less for like cancer or things like that. I haven't used it myself for anything other than vascular diseases, so I can't comment specifically, but I have seen it. I haven't, again, used it for cancer or neuroendocrine tumor or anything like that. What was it applied to, if you don't mind asking or answering?
I saw an educational video on it, and I think it was, I think they were proposing that it be used for liver surgery resection for neuroendocrine. But
so that's a good point. Thank you for reminding me. It is used for liver surgery. When you operate on the liver, the liver is a great organ. It can take a big hit, but it can't take such a big hit, or it could potentially fail. And usually that number is about 30%, maybe 20%, but about 30%. So we generally do this there is 3D modeling of the liver just to see the volume of your liver, so that if we cut it in a certain area, the residual liver that is not removed is at least 30%. So we use it for that, definitely, yeah.
Hi, is the robotic surgery good for diagnosis, such in the case you have positive tests, but they just don't see the nets on a scan?
Yeah, that's a very good question. I wish I could say yes. The only reason why I can't, we use the same techniques robotically to determine where a tumor is that they can still do with other techniques, like an ultrasound. For example, if we're looking at the pancreas and we know there's a tumor there, but we can't localize it extremely well, sometimes we'll put the ultrasound on it in the operating room to localize it very well. But we're hard pressed to take a patient to the operating room to do something like that, just because there are other less invasive techniques that are really good. And I can appreciate that sometimes there are abnormalities in biomarkers like chromogranin levels and so forth, and we can't see things. It's not used for that reason yet.
I'd also add that it's very rare that we need a invasive procedure to make a diagnosis of neuroendocrine tumor. Sometimes patients wonder whether it's needed, but I always tell them that if everything else fails, you probably do not have a tumor anyway. Because the modern imaging and the testing should be able to find the vast majority of a significant tumor. So for example, we can always have a 2 millimeter tumor,
Right.
but it's not a big deal. So when the tumor should not cause a lot of problem. But only when the tumors are big enough, they cause clinical symptoms.
Dr. Heck, you were going to add, I think?
No, I just had a question
No.
for Dr. Yu.
Oh, you guys?
This is for Dr. Yu. First of all, I have double cousins, and so it's not as unusual as you think. My grandfather and his brother married my grandmother and his sister, so it does happen. It does happen. And, but the question is that you did remarkable work in identifying a new syndrome, but that was back in 2008. And then are you set up now to do, since whole exome and whole genome sequencing have gotten so much cheaper, and we have a very large group here at UCLA in genetics, are you set up for patients who may have similar problems to have it was much harder in 2008 than it is in 2016?
So thank you, Randy. And again, Dr. Joe Pasinga here actually is already doing many of them. I think Joe has talked with our group before, right? Yeah. So, what Dr. Heck mentioned was that we have a new genetic techniques now, so we can literally sequence every single gene of our body, or most of them, pretty reliably. In the past, we used an approach called the candidate gene approach. So that is, you kind of guess what could be wrong, then you actually see whether they're wrong. But now we do more like a comprehensive and a little bit sort of adventurous approach, so that you sequence everything. And there are pros and cons to that approach. The pros, of course, you get everything, right? But the cons are that everybody has mutations. Actually, we have an average of about 8 mutations, and they're significant mutations. So no one is perfect. So, but then whether the mutation causes your problem or not is a different story. Actually, more and more studies show that we have been over-interpreting those results. For example, if you see a gene that may be remotely related to your disease, but the gene indeed it has a mutation, right? But in the early days of the new genetic approach, we kind of think, oh, come on, it has to be that, right? But now we realize that even some really, really theoretically bad mutations actually are totally fine. So our body are smart enough to compensate. It's kind of like like what we do in life, that we know we're not perfect, but we can compensate by doing other things to make it work. So I think there are pros and cons of both. And my personal opinion is that I prefer the candidate gene a little bit because I think it's a smart approach, so that you kind of target something. But for the new approach, it's more expensive, also need a larger interpretation, almost an enterprise. You have to know what those genes do. And I think that the best candidate that for those kind of approach that you really cannot see anything that obvious, but the patient is really unique. So there are some features that resembles nothing. Then I think this is the best approach. And the nice thing is that UCLA has one of the national undiagnosed disease centers here. It's sponsored by NIH. I'm not a part of that center, but Dr. Joe, I think, is. And so if you feel like you have a disease that nobody has been able to fit them together into a single diagnosis, you can go to the website. Actually, I talked with a patient yesterday on this. And you submit your case, and they're going to evaluate you. If they feel they are likely going to find something, they're going to fly you here with your family member, stay here for 2 days for free, but they're going to take a lot of blood out of you.
This question is for Dr. Yu.
Hi.
Regarding the familiar NET syndrome, what is involved with the gene testing? Is it a simple blood test or?
Yeah. So the gene testing for the MEN1, MEN2 hippolyndol, these are commercial tests now, so they are widely available. So strictly speaking, you need to see a genetic counselor first to sort of get the understanding of all the ramifications of that. And again, genetic testing sometimes reveals things that we do not want to know. For example, someone may realize they're not their father's son or something, because of genetic testing. But they're very easily done. They're established. But your doctor can make usually the right approach is that a doctor refer you to either a geneticist or genetic counselor first, then we do the genetic test.
Okay, thank you.
A follow-up to the frequency of surgeries.
Mm-hmm.
Is there such a thing as another debulking of the liver if other therapies have been tried and you still have progression?
There is. The therapies are not mutually exclusive of one another. So generally, especially for the liver, there are these like liver-directed therapies I'm sure you've heard about, TACE or TARE or radiofrequency ablation or surgery. And the idea is to use them together because we suspect that the disease will come back at some point. They can be used together to decrease the burden over time and provide a longer overall survival. So yes is the answer, yes.
I had a question for Dr. Yu. There's been some developments in studies on a test that would be a predictive test for NETs based on various biomarkers.
Sure.
Can you comment on that?
Yeah, is that you're talking about the Mark? I forgot his name. Mark from Dr. Richard Watson's group. So that test is being developed. I have no commercial affiliation. That I actually talked with one of the developers about it. So this is basically a blood test. It just tested all the little things a tumor may secrete into the blood, and then the specifics of the materials that they test can predict. So what will the prognosis or recurrence? I think they both that the recurrence detecting sometime is a few years earlier than what a routine imaging or biochemical test will do. I think it's a great approach, but we just need to have more data to show that it actually has real benefit. So I often emphasize, patients often ask if there's a new thing, shall I do it or not? I tell them that the important thing is that do you get a real benefit? So for example, even if we know you have a recurrence, say 2 years before, but we cannot find a recurrence, right? So what are you going to do differently, right? And because we know neuroendocrine tumors are slow growing, but many patients eventually develop a recurrence. But the recurrence may not be very bad, and if we do not have a great treatment, then we may not actually want to know there's an early recurrence. It's kind of like, if I, say, just like if you can now do something anyway, you do not know how good it is. Because even know it, you just feel worse. So I think the real benefit is being tested in clinical trials, and I think UCLA may have talked with them already about whether we should enroll patients. But I think there's a really important question, the clinical benefit, not just some markers of a benefit, but the direct benefit. So does the patient actually live longer, have a better quality of life because of this test, or you just simply know you have recurrence now, but then what do? We can now find the tumor, everything is normal, then you just feel bad, without being able to do something about it.
I have one more. What are you both planning for your holidays?
Well,
Please.
I can actually tell you, I will be on call. So because I'm new to UCLA, they gave me all the holidays in the first year. So hopefully next year I'll do something more interesting.
I just want to ask Amy if she wants to say hello and introduce herself and the group she represents.
Okay, I think I met some of you last month. My name's Amy Powell. I sit on the board of directors for the FEO Paratroopers. We're a group that provides support to NETS patients and specifically to people with pheochromocytoma and paraganglioma, which we see with VHL and MEN type 2. And we want to just let you know that we're here in Southern California and globally. I would be happy to, if any of you do have any questions about familial syndromes and what support groups there might be for you, to answer those questions and hook you up with the right people. And if I can't, I think I can refer you to the people that would. So, thank you.